So Monique did her PhD in my lab, and I was not part of the organising committee in choosing her to speak, but she is now a fellow at Peter Mac in both gynae and neuro-oncology, and has a very targeted approach to life. Thanks, Monique.
So thank you for giving me the opportunity to talk today. Today I'm talking about the risk of acute myeloid leukemia and myelodysplastic syndrome following PARP inhibitors, which has been or become important as the indications for PARP inhibitors has expanded and as the follow-up data has matured. And so when we consider that in the first-line setting, using PARP inhibitors may potentially cure some of our patients, the risk of a secondary malignancy is obviously very important. And secondly, when we consider treating patients without clearly identified biomarkers, where we expect the benefit of PARP inhibitors to be less, it's important that we have the correct data to do a risk and benefits analysis. And thirdly, we're now seeing PARP inhibitors in the adjuvant setting in breast cancer. So the risk of a rare and late adverse events is obviously of a particular clinical significance. And lastly, when we look at re-challenge with PARP inhibitors, or in fact, more importantly, PARP inhibitors in combination with other therapies, the risk of MDS and AML following this is largely unknown. So some of the questions that have been asked in order to understand this risk better is to look at who is at greater risk and how can we identify them. So it's thought that older patients who have increased clonal hematopoiesis, patients with germline mutations in DNA repair genes, which is a common occurrence in our patient population, and also those that have had multiple prior lines of platinum or DNA damaging chemotherapy. And we likely ameliorate this risk now by giving PARP inhibitors in the frontline setting, so therefore reducing a patient's overall exposure to cytotoxic therapies. And by also stopping PARP inhibitor maintenance therapy after a defined treatment period. And that's been evidence from the SOLO-1 trial, where there was evidence of sustained benefit beyond the end of treatment from olaparib. So although we expect that many more of our patients will derive long-term benefit from PARP inhibitors in the frontline setting, it's likely, well, we know many of our patients will go on to relapse and require, so some of those patients will, or a subset at least, a small subset, will derive significant benefit from PARP inhibitor re-challenge, but likely though other patients will need different strategies. So the effect of cumulative PARP inhibitor treatment, the effect of re-challenge with PARP inhibitors, and thirdly, the effect of other subsequent therapies post-PARP inhibitors is really important in our clinical decision-making and understanding of this. And lastly, by understanding AML and MDS that arises post-PARP inhibitor therapy, we're likely better able to counsel our patients, also monitor this disease and recognise it earlier. So there are some challenges in attributing the risk of MDS and AML following PARP inhibitor therapy, and our knowledge is largely derived from initially individual trials, but also meta-analysis and real-world data. There are some significant challenges with individual trials. So initially they were underpowered to examine this rare and late adverse event, and this initially didn't show a clinical significant difference. Because PARP inhibitors, as you know, confer a significant survival advantage, there's obviously competitive bias where patients in the placebo arms die before encountering a secondary malignancy. And also in clinical trials, patients are usually less comorbid, so therefore their background risk of a myeloid neoplasm is likely less. So we can look a bit to the pre-PARP inhibitor era to understand our patients' baseline risk. And in an analysis of the Sears registry database and the US Medicare claims database from pre-2014, they were able to demonstrate that platinum agents conferred a greater than 5-fold increase of treatment-related MDS and AML in our patients, and that this risk persisted for greater than 5 years following diagnosis. And really sadly, that these myeloid neoplasms, so after diagnosis, these patients had a median overall survival of only 7 months. and I might just skip ahead a little bit. So in some further SEERS registry data from even before this time, we can see that the incidence of treatment-related AML and MDS is actually, in fact, higher in ovarian cancer patients compared to many other solid cancers. And the incidence is actually higher in older ovarian cancer patients compared to younger patients, which is not the case or not as pronounced in other solid malignancies like breast or lung cancer. And there's this hints at the underlying biology of our patient population and also the effects of our treatment. So the SOLO-2 early safety analysis is a good example that illustrates how a rare and late adverse event can be underappreciated. So initially, the authors concluded that olaparib did not increase the risk of MDS or AML, initially reporting it with a median follow-up of 25 months at this safety analysis, and this data was actually presented at the 2018 ASCO. They demonstrated the overall risk in the olaparib arm was 2.1% versus 4% in the placebo arm. So they didn't think there was an increased incidence. However, they concluded there was an increased incidence with increasing lines of prior therapy. They demonstrated it was a 0.9% versus 8% in 2 lines versus greater than 4 lines of therapy. But as many of you likely know, in the 5-year follow-up, there was actually 16 cases found in the olaparib arm versus 4 cases found in the placebo arm. So rates of 8% versus 4%, and this is what caused significant alarm and made people take notice. And what we can see is that 9 of the cases in the olaparib arm versus 4 of the cases in the all 4 cases in the placebo arm actually occurred after the safety follow-up period. And if we look at these 16 cases in the olaparib arm, we can see that 10 of the cases were actually on olaparib for greater than 2 years and only 3 for less than 1 year. And it's important to point out that 22% of patients on the olaparib arm in SOLO-2 actually were on olaparib for greater than 5 years. We also have some data some long-term safety follow-up data actually from the NOVA trial, another later line trial, looking this time at niraparib. And this data is informative because we, following the PRIMA trial, the first-line PRIMA trial, niraparib has been approved in HR-proficient tumours also. So there is some limitations of the NOVA trial, so there's some survival data missing in 15% of patients, and participation was affected by the commercialisation of other PARP inhibitors. But allowing for the fact that there was also long-term treatment with 49% of patients remaining on niraparib for greater than 3 years, we can see the incidence of MDS and AML was 3.5% versus 1.7% in placebo. And really interestingly, what they showed was that patients with germline mutations in BRCA, in both the niraparib-treated arm and in the placebo arm, had higher rates of MDS and AML. So looking now at first-line data, the longest follow-up we have is for the SOLO-1 trial, and not only did they demonstrate that there was sustained benefit beyond the end of treatment, so out to 7 years was their follow-up, they also demonstrated that the rates of MDS and AML remain largely at 1.5%. So we can see that about 45% or so of patients at 7 years have not recurred or have not required, have not gone on to further therapies. So if you prevent recurrence, you then reduce exposure to subsequent therapies and therefore reduce the accumulation of further treatment-related myeloid neoplasms. And this was further borne out in a cohort analysis of the ARIEL-2 data, where they demonstrated that number of prior lines of therapy and also extent of therapy was a strong predictor for who went on to develop treatment-related AML or MDS. So the follow-up data from the first-line setting is more immature, but the pooled data looks to be that the risk is about 1%, so significantly less than in the recurrent setting, which is further underscoring the importance of frontline PARP inhibitor treatment. And so, as I said, we know that many patients will derive hopefully long-term benefit from PARP inhibitors, but we know that many patients will recur, and so the effect of subsequent therapy and the timing of those events is of critical importance. And so I wanted to look a bit more at with a bit more granularity at the the neoplasms that arise, or the myeloid neoplasms that arise post-PARP inhibitor treatment. And so if we look at 9 cases now from PALO 1 and 3 cases from SOLO 1, we can see a concerning trend for an earlier latency than what otherwise would be seen in other treatment-related myeloid neoplasms. So they occurred at an average of 18 months from the time of PARP inhibitor initiation. We can also look at safety, a meta-analysis data to better quantify the risk of AML and MDS in our patients. And this was an important meta-analysis published in 2021 in the Lancet Hematology, which looked at 18 placebo-controlled trials across multiple different tumour types. And I've highlighted in pink and purple the ovarian cancer ones. And so they demonstrated that there was an increased risk of treatment-related myeloid neoplasms with a pedo odds ratio of 2.63. Hang on. So they demonstrated that the incidence was 0.73% versus placebo, which was 0.47%. So a smaller incidence, but all of the cases occurred in ovarian cancers, and a median latency was 20.3 months. So again, considerably short. And again, they demonstrated there was an increased risk in the recurrent setting versus the frontline setting, which really suggests that both PARP inhibitors and prior cytotoxic therapy both contribute to the development of treatment-related AML and MDS. Interestingly, and I think this might speak more to how the analysis was done and the data they had on hand, but the subgroup analysis showed that there wasn't a significant difference between those that had germline BRCA mutations versus those that didn't, and also between things such as difference in PARP inhibitors used. So within this publication, they also looked at some real-world data, drawing on a pharmacovigilance database, VigiBase, and they were able to demonstrate again that the latency was short, with the time to development of MDS being 17.8 months, and in AML it was 20.6 months. And again, sadly, they demonstrated that mortality was high, with a mortality rate of 45%, and that's with a median follow-up of only 5.6 months. Really interestingly, and this kind of points to a common hallmark amongst this particular myeloid neoplasm, is that 40% of patients experienced a prior cytopenia, with anemia being the most common, a frequent type, and it occurred in a median of 7 months from PARP inhibitor initiation before developing a myeloid neoplasm. So this is another pharmacovigilance study, this time a disproportionality analysis, drawing on the FDA's adverse events database. And they would demonstrated a dramatic increase in PARP inhibitor-related MDS and AML, with numbers are small, but I think it's 2 at 200, and at 2015 there was only 2 cases, and in 2019 there were actually 115 cases. Again, they showed the median time to onset was only small. In this case, it was 15 months. The most commonly used PARP inhibitor was olaparib, and so the reporting odds ratio for olaparib was 48.03 versus that of the comparator arm they chose, which was bevacizumab, was 4.58. So we can't use pharmacovigilance studies to identify incidence, because it relies on, there is some element of reporting bias. But in a further analysis of the FAERS and EV database, the authors really concluded that there's likely a higher incidence in the real world versus in clinical trials. And what we can see from this pharmacovigilance data is that there's a critical first 2-year period of a critical pharmacovigilance window where the majority of patients develop their myeloid neoplasms. Although there might be some bias here, because the majority of ovarian cancers that do occur in those first 2 years. So I wanted to speak a little bit about the pathogenesis of myeloid neoplasms arising post PARP inhibitor therapy. And there are likely 4 main drivers that are not mutually exclusive. So firstly, patients that have an inherited mutation in DNA damage repair genes, as you know, are more likely to develop multiple independent malignancies, and are likely to, the DNA is more susceptible to DNA damage by chemotherapy. Secondly, we know that cytotoxic therapies drive clonal selection, And so in patients that have a pre-existing somatic mutation, such as in TP53 or clonal hematopoiesis of indeterminate potential, that cytotoxic therapy selects for these clones or gives them a survival advantage over normal clonal hematopoiesis. And we know that clonal hematopoiesis of indeterminate potential exists in about 1 to 2% of healthy individuals. So what that really is a precancerous clonal expansion that confers a significantly high risk of leukogenic transformation, so about a 13-fold increase. And so these exist in about at a much higher rate in those with solid malignancies, about a rate about 5 to 10%. And in fact, in gynecological cancers, they exist at a significantly higher rate with an enrichment of DNA damage repair genes. And so thirdly, we know that therapy itself is a mutagen, and also that cytotoxic therapy can affect the bone marrow stromal niche. So if we look at some case control series now that better help characterise this type of myeloid neoplasm, this analysis looked at 20 patients following PARP inhibitors, mostly those that were treated with olaparib. And again, they showed a really poor median overall survival from the time of these myeloid neoplasms, with an overall survival of 4.3 months. And this is despite 11 of these patients being in complete response from their ovarian cancer. So within these myeloid neoplasms, 75% had mutations in BRCA, 83% had mutations in DNA damage repair genes, and unfavourable cytogenetics was seen in 100% of these. They also showed that clonal hematopoiesis was more common in patients on maintenance compared to those on not, and that they also demonstrated clonal expansion in paired pre- and post-PARP inhibitor samples. And of the same vein, they demonstrated that mutations in TP53 and PPM1D were more common in patients on maintenance PARP inhibitor therapy. And just a second case control series, this time looking at patients from the Ariel 2 and Ariel 3 study, where they were able to collect peripheral blood cells pre-rucaparib, and they looked at 20 cases of myelodysplastic syndrome compared to 44 controls. And so they also demonstrated the prevalence of clonal hematopoiesis variants in TP53 was significantly higher at PARP inhibitor treatment initiation in those that ultimately went on to develop myeloid neoplasms. And not only that, they also demonstrated that these variants were higher in patients with longer overall prior platinum, which does give us some rationale for why patients with prior platinum may have a higher risk of these neoplasms. And furthermore, in this same publication, they looked at the prevalence, which they demonstrated was higher in patients with ovarian cancers with homologous recombination mutations. But interestingly, they didn't show that there was a difference between those patients that had germline mutations versus somatic homologous recombinations mutations in their ovarian cancers, but rather that these patients were more likely to encounter more courses of chemotherapy. So it doesn't necessarily, it's not automatic that patients that have germline mutations in, say, BRCA1 or BRCA2 are at a higher incidence of developing these myeloid neoplasms, but maybe if they have many more lines of therapy. So we can also characterise these tumours a little bit by some learnings from some further single institutional studies that have happened over the last 2 years. I don't have time to describe them, but I wanted just to describe some of the pooled learnings. So they also, the authors in these studies also concluded there was a higher rate in the real-world setting compared to the randomised clinical trials. And the common hallmark was persistent cytopenia, noted after PARP inhibitor suspension. And this can help us discern in our patients that have that transient myelosuppression, so discern that from, say, the more serious myeloid neoplasms that we see post-PARP inhibitors. They also demonstrated there was a relatively rapid onset, and that sadly, despite really aggressive treatments described in some of these papers, that the mortality rate was still significantly high. So there were some common characteristics. They demonstrated complex karyotypes with frequent involvement in chromosomes 5, 7 and 17, and a predominance in TP53 and other DNA damaging repair mutations, suggesting a central role in the pathogenesis. So just to summarise the pathogenesis a bit better, so PARP enzymes and P53 play a crucial role in DNA repair and genomic stability, and TP53 mutated cells are highly dependent on PARP inhibitors for repairing DNA. So PARP inhibitors likely select for pre-existing TP53 chip variants that, under the pressure of platinum, creating a bottleneck effect, creates clonal expansion, and then creating more genomic instability in the accumulation of these additional somatic mutations, leading to this leukemogenic transformation. So ultimately, pre-existing TP53 chip variants under the pressure of prior platinum or chemotherapy, plus PARP inhibitors on top, and then possibly the addition of some germline predisposition contributes to the development of these neoplasms. And this creates a neoplasm with a myeloid neoplasm rather with high genetic complexity compared to your de novo myeloid neoplasms, and that probably explains why it's extremely poor outcomes despite these intensive therapies. I'm nearly done, but I just wanted to demonstrate some really interesting preclinical work that was done at the WEHI that shows some a really promising strategy that could be potentially looked at in the clinics, where they demonstrated that selective inhibition of CHEK2 may actually spare blood cells from the toxic influence for PARP inhibitors. So PARP inhibitors rapidly induce both cell death and cell cycle arrest in blood cells, and that the acute effects relies on the activation of the P53 pathway. So CHEK2-dependent P53 activation is crucial for PARP inhibitor-induced cytotoxicity in normal blood cells, and that genetic or pharmacological inhibition of CHEK2 blunted PARP inhibitor response in lymphoid and myeloid cell lines in both in primary murine pre-B and pro-B cells. And they were also able to demonstrate that co-treatment with CHEK2 inhibitors did not antagonise the APA response in ovarian cancer cells. And it'd be interesting to see what the safety of this strategy is and the effectiveness in the clinical scenario. So just to summarise, I think we've moved beyond the PARP inhibitors for all strategy, and that we should use judicious use of our cytotoxic therapies in order to really use a preventative strategy for the development to prevent the development of these treatment-related AML and MDS. It's obvious that prior chemotherapy and prolonged PARP inhibitor increases the risk of AML and MDS, and the first 2 years of PARP inhibitor exposure are likely the most critical. And so the other thing for clinicians too, it's important that we continue to monitor patients beyond just stopping their PARP inhibitor therapy. It looks like from the pharmacovigilance studies that we need to consider continued surveillance for at least 7 months post-stopping, and that the outcomes remain poor in these patients who do develop these neoplasms. I just had a couple of points in terms of unmet needs. So we obviously need some real-life, longer follow-up term data. We need predictive biomarkers, and we're starting to see now prospective screening or pre-screening in some trials of these clonal hematopoiesis mutations. We don't yet know the contribution of BRCA or HRD, and we don't know the effects of PARP inhibitor combinations. And on a positive note to leave on, we now highly selective PARP inhibitors will likely hopefully reduce this risk of hematological toxicities, whilst also confirming a significant benefit for our patients. So thank you.
Thanks very much, Monique. It was a huge amount of data, and it's really interesting, isn't it, to see such an historic story now seen in retrospect. I would like to acknowledge Sue, who was on a PARP inhibitor for 10 years and died despite being on a clinical trial for MDS AML. So you can see it at any stage. But I think that the data that you've pulled together is really very important, and just open the floor to questions while pondering on those PARP1 specific PARP inhibitors that are yet to come.
Great talk.
Thank you.
Is it clear that it's platinum, do you think? Or is it really difficult to untangle that just in terms of numbers and co-treatments with different things?
I think it's different. So, I think platinum definitely contributes. But if we look at even like the data from when I was born, so when they were using radiotherapy and melphalan, there was obviously, I think there's different contributors. But I also think that probably ovarian cancer patients probably as a baseline risk probably have a higher propensity. Maybe there's something about the biology that contributes not to the development of ovarian cancer, but maybe to myeloid neoplasms as well. So I think it's probably a bit of a perfect storm.
It's not that they just see more platinum than other people?
I think that's part of it, but I think that if we look at the randomised controlled trials of PARP inhibitors in other tumour types, we're probably not seeing the same rate, and I don't think it's just platinum alone. Yeah.
Oh, that's a fantastic talk, and I might kind of flag a study that many of you hopefully will see quite soon. As we are about to start a survey trying to ask a really important question regarding the duration of maintenance therapy in patients who are receiving PARP inhibitors, who are exceptional responders with platinum-sensitive recurrent ovarian cancers, because there are an increasing number of people who have been on a PARP inhibitor for more than 5 years. And with very few exceptions, we don't actually have good data on whether there's a cumulative risk in those long-term survivors, because most of the leukemias and MBS are seen quite early in the first couple of years. And I mean, apart from Claire's patients, the only one I know of, there are very few have been diagnosed. So it's a really important question regarding how long we continue on PARP inhibitors, and many people in this room will be getting that survey shortly to try and collect that data.